Hello, today we're going to explore the factors that are related to speech sound disorders. So far, we've been working on reviewing some of the material to which you were introduced in your first phonetic course and going deeper with some concept and with the details of the description of consonant and vowels and their distribution in English and also how consonants sound in other languages. We also discussed intonation in English. Today, before we move on to the next chapter, what I want to do is give a general overview of the factors related to speech sound disorders. And this overview will motivate the next sessions that we're going to go through, for instance, looking at development, the acquisition of speech sounds. Okay. So the first set of factors that I'm going to explore have to do with the anatomy, neurology, and general physiology. Which of these factors may impact speech and articulation. The next one has to do with motor skills, and we'll talk about sensory variables, how speech sound disorders relate to language skills, whether there is prevalence in families, and the logical and conceptual problems that are related to these issues and the methodological issues that people have to face when conducting this type of research. So if we take the anatomical structures that are involved in articulation and we go from the front of the mouth to the back, we have the lips. And so the first topic we're going to talk about is whether it's important. So first of all, in terms of proportion, size, and shape, there is much individual variation with respect to the lips. But and of course, the lips are especially important in the production of bilabial sounds like p and b and where they are in contact with one another. So the size, the mobility of the lips vary across individual, but within certain limit. We know. I mean, there is no. As long as you are within the normal range, there are no issues. So it's only in the when there are some serious issue with lips, such as the case of cleft lips, where, and especially severe cases, where you may have issues with speech production, these are usually corrected by surgery. Okay. There are also patients who have a short and stiff upper lips following cancer and part of surgery that may have removed part of the lips. But even that, in many cases, the patient managed to have compensatory mechanism, so their speech production sound within the normal range. Okay. But those that have lip structures that are very altered may have issues, but still most of them manage to develop their own compensatory mechanism that helps them to sound relatively intelligible. So next, after, if we move back in the mouth, then the next thing we have teeth. And the issue here is the occlusion of the teeth, that is, how the teeth align when they meet, when your mouth is closed. And if you look at the diagrams on the slide diagram, the drawings A, B, C, and D. So A represent what's called the normal occlusion, that is, the teeth, the front, the upper and lower teeth are exactly aligned with one another. Now, I would like you to close your mouth and leave your lips open and check if you are if you fall under A, and if you don't, well, many people fall under B, and it's a very it's a malocclusion in the sense that the upper teeth are placed in a position, are in front of the lower teeth. They are not aligned. And then it's a much more drastic one when you look at C. And then D, it's the teeth are not aligned, but it's the other way. It's the lower teeth that are placed more in front than the upper teeth when your mouth is closed. Okay, so so this malocclusion refers to the fact that the mouth doesn't close in a way that the teeth are aligned. Do they affect the production of sound, especially given that the teeth are an important articulator, in the sense that they're important in producing a labiodental, like and V, where both the lips and the teeth are involved, or dental, linguodental phoneme, like th and the dental fricatives. So are they, what happened? Are these consonants affected by either this malocclusion or other issues with the teeth? Okay. People have studied the relation. I mean, people used to study, such as Fairbanks and Lintner in 1951. People looked at the correlation between dental occlusion, whether, if you have A, B, C, and D, whether you are more likely to have articulation disorders if you have malocclusions. So if you fall under the category B, C, and D. And as you may have noticed, there are people around you who have these malocclusions, and what the research suggests is that basically even people who have malocclusions, they tend to have exhibit articulation disorders. Okay. So it seems that also if you have like severe malocclusions, you may have more chances to have articulation disorders. The relationship between these and is not very strong. That is, that it's not everybody who has malocclusion. It's not everybody whose teeth are lying like B, C, or D who necessarily exhibit articulation disorders. And the other issue is that when you have other types of dental issues, it's the same thing. If they are severe, there might be some issues for a while. With children, it's like their teeth grow, so it's not always the case that everything stays the same. But it seems that dental deviations are not responsible for many articulation disorders. Okay. So that's important. Another important, extremely important articulators, given that the position of this articulator determines is very important in both the production of consonants and of vowel, is the tongue. Okay. So there are different issues that have been identified with the tongue, and that may have an effect on articulation. The first one is that is listed here is ankyloglossia. Ankyloglossia is also known as tongue-tied. Okay, and what it is that the membrane that that is underneath of the tongue and links the tongue to the rest of the mouth is shorter. Is short, and therefore the movements of the tongue in the mouth are restricted. Okay. So again, here there is some amount of variations that is okay. So it's not the case that all so this membrane underneath the mouth is called the frenum. It's not the case. So frenum, F-R-E-N-U-M. Okay. It is not the case that everyone everyone with a slightly shorter frenum has issue with articulation. But there can be a certain amount of variation in the size. With respect to on the other hand, there are some cases that are very severe cases of ankyloglossia. So the first thing to remember is that when a child is born with ankyloglossia, it's not necessarily the case that it's going to stay. Some children outgrow it. That's why some pediatricians recommend a wait and see policy. It seems that based on surveys that have been done in the field, surveys that were conducted with pediatricians and speech-language pathologists, it's not very clear the incidence of problems that are articulation problem tied to ankyloglossia or this issue of being tongue-tied. The prevalence is not very clear. Okay. However, in some cases, the child outgrows the ankyloglossia, in which case, which explains why some pediatricians have a wait-and-see policy, whereas in other cases, there can be minor surgeries that provides the help needed. Another issue that may affect speech intelligibility. So we've talked about ankyloglossia that has to do with the ability to move the tongue in the mouth. That is partly depends on the size of the membrane under it. The next issue has to do with what's called glossectomy. Which is glossectomy has to do with removal. So it's when you have cancer of the tongue or when you have some tumor, etc., and smaller or larger proportion of the tongue is removed. So the surprise here is that some adults and children who undergo this type of operation seem not to have as many articulation disorders as you may expect, but it could be that they still have some issue with certain type of sound, especially fricatives and plosive. It depends, and of course, if they do, this affects their intelligibility. When such operation takes place, when the removal of the tongue or part of the tongue happens to young children, it seems that if they receive systematic treatment, they develop mechanisms so that the treatment enables them to develop compensatory mechanisms. So that they manage to use the tongue they have in order to produce speech that is close to being normal. Okay. Basically intelligibility partly depends on how much of your tongue has been removed and to what extent you've been able to develop compensatory articulatory mechanism. By compensatory mechanism, I referring to mechanisms that you use instead of the typical one, but that will enable you to produce the same or similar target sounds as the one you would with with your tongue being normal size. Okay. So what's important to remember here is that the effect of issues with the tongues may be more limited than what you would expect, and that when there are negative effects on speech production with respect to rendering the speech partly unintelligible, people can develop compensatory mechanism which emphasize the fact that the tongue is adaptable and flexible with respect to how it can produce the movements that are involved in speech production. So again, if we move in our mouth, then we are reaching the hard palate. And again, the hard palate is not exactly the same width, length, or height across individuals, but some normal variation doesn't create any issues for people with in terms of speech production. However, one of the issues that affects speech intelligibility is a cleft of the hard palate, and if it's not closed, so what happens with when we talk about cleft palate, we're talking about an issue with respect to the separation between the oral and the nasal cavity. Okay? And this issue creates, of course, problems when it comes to feeling. And then it creates serious problems for speech production, which is why today in the Western world, in places where people are able to do so, usually there is surgery within 2 years, in the first 2 years of life. Now the issue with surgery, and the thing to remember, is the fact that, as we'll discuss when we discussed acquisition of speech sounds, the size of the mouth, and especially the relation of the articulators in terms of their size in relation to each other change. So it's not the case that your articulators have exactly the same proportions as they had 10, 15, 20, 30 years ago when you were a child. Which is, so what that means is that when you have surgery for cleft palate, you can't just have surgery once, okay? So that's very tricky. If there is a cancer of the hard palate and it needs to be removed, it affects speech intelligibility, but usually what happens is that patients receive palatal prostheses in order to be able to have a separation between the oral and the nasal cavity. Okay. So basically, with the hard palate, its size, its shape, etc., there can be some degree of variation, but if there is a serious issue like cleft, which prevents the separation of the oral and nasal cavity, then you are going to have all kinds of problem producing speech. The next structure is a soft palate. And the soft palate is essential to the velopharyngeal mechanism that involved in the production of speech sounds and the resonance. Okay? So this velopharyngeal mechanism, it connects or disconnects the oral and nasal cavity. So if you didn't have this mechanism, there would be nasal resonance in oral sounds, okay, which is why people who have like cleft palate issues, one typical issue has to do with the nasalization. And also you would have issue in terms of building pressure in the oral cavity, air pressure, in order to produce fricatives, stops, and affricates. All of these are known as pressure consonants. So sounds like sh, v, z, stops like b, p, g, and affricate like j, that consist of a combination of plosives and fricatives. Okay. So what is known as what is called velopharyngeal inadequacy or insufficiency refers to the fact that refers to the difficulty in separating the nasal from the nasal cavity from in order to produce the oral sound, and it prevents you from bleeding pressure inside the oral cavity because the air leaks through the nasal cavity. Okay? So the result of this issue is that you have a very weak, you don't have the strength to produce consonants such as fricatives and plosives. So of course here again, when patients suffer from this, from velopharyngeal inadequacy or insufficiency, what happens is that they tend to compensate, and one way to compensate is that they produce sounds, with more towards the back of the mouth. Okay, so for instance, the plosive p, b, t, and d are replaced with a glottal stop. Okay. And the same, the k and g sound are produced more at the back of the mouth that produces like pharyngeal stops of air, and the same with fricatives. Okay. So you have a lot of distortion of sound, and in addition to that, you sound what's called hypernasal. Okay. Because basically you sound like you're producing nasal sounds even when you're producing oral sounds. Okay. So the conclusion with respect to this section is that the soft palate is very important in articulation, and when the soft palate is affected in a way that you experience what's called velopharyngeal insufficiency or inadequacy, you have various compensatory mechanisms that result in substitutions of sounds. You have weak production of consonants such as plosives and fricatives, and you have hypernasality. Okay? You sound hypernasal. Okay, the next issue to discuss has to do with neurological factor, because what's important to remember is that it's the brain that enables us to control the muscles of speech, and the muscle and the movements involved in speech production. Okay, if the nervous system has issue with any of the mechanisms that are responsible for controlling the muscles, then whether it's a question that these are damaged, or there is some uncoordination, or there is paralysis, they tend to be effects on, so when this happens during the course of development of acquisition of speech sounds by children, the learning of the speech sound may be affected negatively and very seriously. The child may misarticulate many different sounds. Okay? And if this occurs in adults, if neurological structures that underpin the speech production mechanism are affected in adults, then what happens is that those adults who used to who have acquired and produce speech normally, they lose some of their speech characteristics. They lose their ability to produce certain sounds, etc. Okay. So among the speech disorder, so with respect to so I want to talk briefly. We will explore these issues in more depth in later parts of the semester, but briefly there are at least 3 issues that are associated with this type of factor, and these are dysarthria, which is when the central or the peripheral nervous system is damaged, and the muscles that are responsible for that are involved in speech production are weak, they lack coordination, or they may even be paralyzed. In adults, this is often associated with strokes, tumors, infectious disease, toxic factors, etc., brain trauma. And speech problems are not the only issue with these patients. There are also issues with breathing, with voice, etc. The next one I want to briefly discuss is cerebral palsy, which is a neuromotor disorder in children. And it's usually described as congenital, but sometimes it's the injury to the brain actually may have occurred after birth. Okay? And many of the disorders associated with this issue are also go under the issue of dysarthria. So with these 2 cases, dysarthria and cerebral palsy, there was damage to the peripheral neural mechanism that is the fact that the brain is responsible for controlling the peripheral neuromuscular mechanism. Okay. However, the issues with speech sound production can also be affected when there is central nervous damage. And this is what happens in the case of what's called apraxia of speech, when the speech motor programming areas, so the areas that in anatomy of the brain you probably refer to as Broca's area, and related other areas are damaged, then you have apraxia. Okay? And apraxia of speech, what is involved in this issue with this disorder, what is associated with this disorder, is the fact that the position of the articulator is not accurate. And so the fact that you can't place the articulator appropriately in your mouth, it triggers a lot of substitution, distortions, omissions, etc. There are many issues in terms of exactly defining this disorder and describing it and categorizing it, and we'll talk a little bit later about it in the during the semester. But one thing that you have to know is that it is related to it is a consequence of neurological issues. Okay? And so it's very important to remember that an intact brain is crucial to the ability to produce speech sounds. Okay. Okay, so if we talk about speech production, we're talking about a type of motor skills. Movement are involved in the production of sounds. And we're talking, especially if we separate motor skills into two categories, like gross motor skills that generally refer to as the movement of the limbs, etc., versus fine motor skills, which is the movement of much smaller movements. So speech production involves fine motor skills. So one of the issues that people have asked is whether there is a correlation between general motor skills in children's development and normal articulation. So different so it's not clear that there is a correlation between general motor skills that involve other muscles and other parts of the body than those involved in the articulation and sounds, and articulation. Okay. Also, it seems that there is some degree of correlation, but there is a lot of disagreement about this in the field. When it comes to the motor skills involved in oral facial structures, so if there are issues with this, then it seems that there could be issues with articulation. And this partly motivates the use of a tool in assessment that measures what's called the diadochokinetic rate, and also known as DDK rate. And this is the ability to produce syllables as quickly as possible, and especially syllables such as putaka. So you ask a client, either a child or an adult, to produce this syllable, to repeat them, to kind of produce them as quickly as possible. And what happens is that the clinician counts the number of syllables rapidly produced after they tell the patients have so much time to produce these sounds as quickly as possible. And there are some norms associated with different ages. And it has been found that generally children who exhibit articulation disorder tend to have a slower DTK rate than children who exhibit typical development. Okay. With respect to growth and changes with this rate, children attain adult-like levels sometime between 9 and 15. So the important thing is that it seems that a slow DDK rate tends to be associated with articulation disorders, but we also have children who have articulation disorders and who have a normal rate. Okay, so it cannot be your only tool when you're assessing clients. Okay? Okay, the next issue has to do with sensory variables, and the first one is hearing loss. Hearing loss can be more or less severe. It can be congenital, it can be there from the beginning and inherited, or it can be acquired. Now, this is an extremely important topic because, for instance, A third of, according to a study by Schreiber and Spies in 1983, a third of the children's articulation disorders were found to be associated with repeated middle ear infections. Okay. Also, if you look carefully at the data on middle ear infections, so one of the consequences of not having systematic healthcare for young children, which the current president tried to change, one of the consequences of this is that middle ear infections are often not identified when they happen in those that do not have the healthcare they need. And a lot of many minority populations in this country have more issues with this. I mean, it's not that there is a higher incidence of middle ear infection if you are Black or Hispanic, but it is that because there is less access to medical care, these middle ear infections are not identified and not treated, and they can have really negative consequences on children's speech and articulation. Okay, so I don't know what the figures are, but right now, but I know that this is definitely a health issue that affects differently people who have access to healthcare or not, simply because, as I say, it's not the case that you have more incidence of this middle ear infection based on your socioeconomic status, but you have a difference in terms of treating them and getting rid of them and not letting them affect your hearing so much that it's going to affect your speech and articulation. Okay, so it is a very important issue. Normal hearing, I mean, intact hearing, normally developing hearing is very important in that this is what constitutes the input to, in terms of what we are going to produce. So in order to develop, in order to be able to distinguish the sounds we hear and also to develop representation with respect to the rules and constraints of the language we are exposed to, hearing is very important. So when it's not intact, it has negative consequences on speech production. Also, when you produce speech, you learn to produce speech by listening to other people, but also as you speak, you hear yourself, and you also have this issue when you cannot hear. So we know that hearing is very important, and it affects the production of speech sound and the acquisition of speech sound. So the questions are, what are the important factors associated with hearing loss that impact on the severity of the articulation disorder? Okay? So the first thing is whether the hearing disorder is there at birth or not. So whether the age of onset of the issue. And of course, the earlier the onset of the hearing problem, the more severe the issues are going to be. The other factors is the severity of the hearing loss, how well somebody hears. And a severity of hearing loss partly depends on the type of hearing problem. In general, for instance, sensory neural loss that has to do with issue with the inner ear or the neural pathways that carry the message to the brain tend to be more severe than conductive loss that has to do with issue with the outer and middle ear. Okay. Another factor that should make you happy, in the sense that what that means is that clinical work has an effect in a way, is that The other factor that's important is at what age clinical services were received by the child, at what age was treatment initiated and implemented, and also the quality of the treatment, of the interventions that the child receives. So basically this the earlier the age at which services are initiated, and the more comprehensive in the sense of encompassing different aspects of the speech production, the more intensive the rehabilitation services are implemented, the lower the effect on subsequent speech acquisition and articulation. So there are a number of issues that are typical of, in terms of speech characteristics that are typical of children with different degrees of hearing loss. You may find more omissions of final consonants in these children's speech. The final consonants may be produced very weakly. Among these final and initial consonant, S is omitted more consistently, and you can see, how it can create issues with intelligibility. S in English can, at a grammatical level, can indicate, for instance, the difference between singular and plural, book versus books, and it's more likely to be omitted. The substitution of voiced consonants for voiceless one, so te instead of de, sh instead of je, etc. There are also issues in terms of substitution of vowels. The sound may not, it's not only that the sound may be substituted or omitted, they can also be distorted. And by this, what I mean is that, for instance, in the production of plosives and fricatives, so per, te, ke, etc., these may not be produced with enough force. The vowels may not be produced in a way that's precise enough, and often they can be too long on the whole. They can be also hypernasality, especially when producing vowels. There can be a change to the syllabic structure by adding vowels between consonants, such as instead of producing something like blue, belu, belu, where you make you instead of the cluster bleu, you produce a syllable belu, and then the second one. You could have an inappropriate release of the final consonant, in the sense that, for instance, we talked about the fact that with plosives in English, in certain contexts, they tend to be aspirated, but this is not the case when they are at the end of words. Well, in people with hearing disorder, you may hear mop aspirated instead of mop. The rate at which they speak may be lower. There may be more frequent pauses. There may be some inappropriate stresses on syllable, and there can be use of a speech that is either too high or too low. And also the prosodic features may be affected. So the kind of what we talked about in terms of different types of intonation corresponding to different meaning, that can be negatively affected as well. So the middle ear infection I was just talking about are very important because they can affect speech production in the same way, but and also the fact that many children who have this repeated ear infection may reach normal articulation, but some articulatory issues can remain in about a quarter of them. So that's so I mean there is also conflicting research in this area. However, it seems that it's very important to identify these middle infections and treat them as soon as possible, because if they occur repeatedly, then they can really affect the acquisition of speech sounds by children. Okay, the next issue has to do with what's called auditory discrimination of speech sounds. That is the ability to pay attention to the different features and of speech sounds, and for instance, the difference in voicing between the D and the T, or the difference in position between the F and the S, etc. Okay. So as you see, when you as you observed while we were describing consonants, for instance, the phonetic inventory of any language involve phonemes that are relatively close to each other in terms of their distinctive features. What I mean by this is that some phonemes differ from each other by just one feature. And this difference may be meaningful in the case, the difference between bin and pin, it's not the same meaning, okay? So in the ability to understand and produce sounds relies also on our ability to make distinctions and pay attention to these features, even if we do not do it consciously. And again, the research is complicated and partly depends on the tasks that are used in order to assess auditory discrimination. So whether children are asked to point out the differences between two sounds, or whether children are asked to group sounds, or asked to distinguish between correct and incorrect production. And it seems that the relationship is not very clear, in that according to a study conducted by Locke in 1980, he showed that most children, his study focused on children with articulation disorders, and he saw that most of them were able to distinguish the sounds, to distinguish between correct and incorrect production, including when it involves sounds that they themselves do not produce accurately. Okay, and other investigators, such as Ellis and Ola, have replicated the study. So what's interesting is that while there is some evidence that children who have articulation issues are able to distinguish between the sounds produced by another person, sometimes they do not realize that they misarticulate. So it seems that when there is a discrimination disorder, it's an additional issue, but it's not clear how tightly related it is to articulation problems. What about oral sensations? So we develop habit with respect to producing sounds based on where our articulators are in our mouth, etc., in relation to each other. And again, this is not a conscious process. However, it's there. So what's called oral kinesthetic sensation has been explored in relation to whether, if this is affected, whether the issue with speech production. Okay. Again, it's not the case that children when this has been examined in children in various ways by making them reflect on giving them giving them, for instance, drawing of objects that would enable them to help explain what goes on in the mouth, and giving them choices of different shape, etc. But also some people have tried to, for instance, to anesthetize by part of the mouth to see what happened in terms of, so this is an experience of sensory deprivation, what happens in terms of speech production in these cases. And again, the evidence is kind of messy in research. So it does seem that some children who have articulation issues also have issues with those oral sensation in terms of discrimination. Other studies have shown that there is no difference between children who articulate and those who don't have articulation issues, and children who do, with respect to the ability to use this oral sensation. Okay. So these are all the sensory variables that are relevant to speech and articulation. Okay, what about language skills? Okay, so it is this is very, very important, because it's a very important topic, because basically the issue with articulation, so speech disorders and language disorder, it's not a systematic association, but it's found in 50% of preschool children. Okay. So what it means in terms of concept, I mean, if you think about it in terms of your assessment, there are at least two possible conclusions. One is that because it's 50%, it's not 100%. So it's not after you have assessed a child's ability to produce sound, so you've assessed speech, that you should not assess language, because the two don't exactly correlate. Okay. However, so language meaning the ability for children to use words in different contexts, the ability for them to use grammatical rules when they produce sentences, etc. So this association is not systematic, but it's relatively strong. I mean, it's 1 out of 2. Okay, we'll have surface articulation disorders as well as language issues. So you cannot, you cannot deduce that a child will systematically have language disorders as speech disorder, or vice versa. But there are high chances. So when you do your evaluation of this child who has exhibit either speech issue or language issue, you should also assess the other one. So if you have a child exhibiting speech problems with articulation of certain sounds, etc., then you should assess their language, and vice versa. If there have been reports of the child language skills, like production of sentences, etc., being affected, child producing shorter sentences that you would expect in the age range, or not producing certain phonemes, certain morphemes, at an age when you would expect them. So not knowing and not producing books when they mean more than one, etc. With respect to morphology, or producing sentences that are much shorter in terms of number of words than their age peers, then you should definitely assess speech, okay? Because one case out of two, you may find an articulation problem, okay? When it comes to phonology, which is, as I mentioned earlier in my lectures, the organization, the knowledge of the organization of the speech sounds in your language, and different rules that and constraints that apply to a given language with respect to the type of phonemes that are found, the type of combinations that are possible, etc. With respect to this level of issues and language disorders, there is a relationship like between 40 and 80%. So again, when you have this more abstract issue with respect to phonological processing in children, and you notice there are some issues, you should definitely test language and vice versa. So what about reading skills and articulatory proficiencies? So the ability to articulate sound, is it linked to reading skills? So, the process of learning to read happens later than the process of starting to learn how to produce speech sounds. But at the same time, especially when you write an alphabetic, when you use an alphabetic writing system, you rely on the ability to link the grapheme, the written symbol, to the phoneme. So the question is that going to be an issue with your, if you have problem with your articulation? Well, again, some research reports that there is a link between the two, and the ability to learn to decode when you read, and other researchers show that there isn't. So there is a lot of contradictory findings. However, in recent years, where people have done conducted more studies on phonological awareness. So phonological awareness is not the same as articulation. Phonological awareness has more to do with phonology, built on phonology, in the sense that it's the ability of children to kind of to become metalinguistically aware, of children and adults, to become more metalinguistically aware of the different phonemes that compose the words. So you're able to identify rhymes, you're able to produce a word that has the same sound, let's say, except the beginning of the word or the end of the word, etc. Phonological awareness, which is something that teachers work a lot on in preschoolers, even before they learn to read formally, and of course that teachers use when children start to learn to read more formally. Phonological awareness has been tied to reading abilities. Okay, so these are all of these associations are important for assessment. So this issue of if you have phonological awareness issue, if you have phonological issues that are going to lead to phonological awareness issue, if you have articulation issue, and whether you have reading skill issues, all these things should tell you something about the need to assess these different areas. But in terms of a clinician, another issue once the evaluation is done is if at least two of the aspects of speech and language production are affected. Let's say that you have a child who has both an articulation and a language disorder, a child with a speech and a language disorder. There is also an issue about treatment. Are you supposed to focus the treatment on only one issue and then move on to the other? Or if you focus on speech, does that mean that the language will improve, so you don't need to do anything necessarily, you just need to target one? Well, basically, this hasn't been found. So what has been found is that what most of the research seems to have shown is the fact that the areas that seems to show improvement is the areas that is treated. That is, if you focus your intervention, if you have a child with a speech and language disorder, and you focus your intervention on trying to get this child to improve their speech production and their articulation, then it's not necessarily the case that their language, their ability to construct sentences, etc., is going to improve. Okay, and it's so what is, and also the other thing is that it doesn't seem that because you work on one area that you can't work on another area concurrently. Excuse me, you cannot, it's not because you work, you try to improve one area that it's going to be an issue to develop a treatment for another area at the same time. Okay, so basically the general consensus that has emerged from research is that you should address both issues separately. Okay, so you should think of a treatment that addresses the articulation issue in the case of a child with speech language disorder, and another treatment that addresses the language issues, and you should implement those at the same time. So what about personal, environmental, and family preference, and also what's called tongue thrust? Okay. So age is a very important factor because you don't when you're very small, it takes a while to learn to produce speech sounds in a way that is adult-like. Most children tend to exhibit, most typically developing children, it takes them up to age 4 to produce speech that is mostly intelligible, and that starts to become close to adult, but there are still different phases of development up to age 8. But before age 4, there are a lot of, it's not the case that articulation is adult-like in children, which is why we're going to spend much time on, we're going to, after the spring break and after your midterm, we are going to spend much time discussing phonological development in detail. Because basically it takes a while for children to become adult-like and to become intelligible, and at the same time, despite this issue, you have to, it's given that it's better to, in many cases, it's better to diagnose early so that treatment can be implemented early. So that gives us a challenge, the fact that children are not adult-like for quite a while, and at the same time they may exhibit disorders, so how to go about identifying them in terms of separating those children that show typical development versus children who show atypical or delayed development in their articulation and phonological development. Gender, or I prefer to call it sex, because I feel in younger children it's not really a choice of identity, it's more biological, is associated with, it's a kind of typical variable. In general, so that's a general tendency, girls tend to master sounds sooner than boys, although the difference may not be statistically significant at different phases. This is so again, it's not the case that you cannot find a single boy who is more advanced than a given, a girl. You probably know some children where the boy, but if you take groups of boys and groups of girls, they tend to be this general tendency. Okay. And then, as in the cases of many other disorders, there is a higher incidence of articulation disorders in boys than in girls. So what about the next variable here, which has to do with intelligence? Okay, so intelligence is typically measured with different tests that do not necessarily rely on. So there is verbal intelligence, non-verbal intelligence, and non-verbal intelligence that includes tests that have to do with standardized measures looking at children's ability to or people's ability to produce drawing, to find, to reason, etc. Okay. And again, this factor is a little bit trickier to explore. So it seems that when children are within a normal range of intelligence, within normal scores, there is a negligible effect on articulations. That is, it's not like the more intelligent you are, the better your articulation will be. There is no link between these cognitive abilities and articulation. However, when children fall between much below the norms in terms of their IQ, when children exhibit extremely low cognitive abilities, there seem to be a prevalence and frequency of articulation issues. So there are some children who have much lower intelligence, who have delayed development in that area, who do exhibit typical articulation patterns, but the majority have issues. So, for instance, if you think about children with Down syndrome, so even if you only consider those who do not have, many children with Down syndromes have impairments, hearing impairment. Even if you take children who don't, many of these children have articulation issues. What about the personalities of the children? Well, this was a type of research that was research conducted back in the 70s, but it's very difficult to conduct this kind of research. Like, first of all, what aspect of one's personality do you expect to be linked to good or bad, like a better or worse articulation? More recently, there's been research on whether children with articulation disorders are more sensitive, but it's not very, none of this research is very conclusive. What about socioeconomic status? So before you come to a conclusion about before we discuss the conclusion that what the research says about this, I want you to think about the fact that when you studied language acquisition, you probably studied the effect of socioeconomic status. And socioeconomic status is like a kind of complex concept. It involves not just how much your parents earn, but their education, etc. And mother's education, maternal education often being a very important component of that factor, of that multi-dimensional factor. And with respect to socioeconomic status, so with respect to what aspect of language is affected by socioeconomic status, so there has been many famous studies that you've probably heard of in your language acquisition class on the fact that, for instance, children in the higher classes the children of the higher classes tend to produce more varied vocabulary than the mother talking to lower SES children. Okay, so you have a very important aspect of language development that is affected by that seems to be the most often the most systematically affected by socioeconomic status is the development of lexical development, the acquisition of vocabulary. Okay, if you think about it, when you learn, first of all, it's very difficult as a child to learn words that you don't hear, right? So you need to be exposed to these words, and you need to have there must be discussions of the concepts that these words underpin for this acquisition to occur. Now, learning the phonological system of a language, it's not that learning words, inside the number of phonemes that belong to a language is a finite number. Okay, there is no, with respect to vocabulary, even today, you still learn new words in your language. Okay, so this learning of new words is kind of never over in a way in our life. Okay, as opposed to it's not the same with the learning of phonology, in the sense that what you need to learn is you need to learn a certain number of phonemes and you need to learn how they combine. Okay, so in that sense, learning phonology is a little bit more like learning grammar. Okay, so with grammatical development, although it has been shown that it can be affected by SES to a certain extent, it's much more limited. The influence on early stages of grammatical development are much more limited than in the case of vocabulary development. Okay, so similarly, and not surprisingly, it seems that there is no significant relation between socioeconomic status and articulation issues. It could be that, especially when you take into account, the appropriate variety of the language to which a child is exposed, and we'll talk more about this as you may have done the activity or not, depending on the order in which you are covering the material that we're covering. What about birth order and number of siblings? So birth order and number of siblings have been shown to have some effect on grammatical and vocabulary development by authors such as Erika Hoff. So what about phonology? Well, so the idea is that when you have more siblings, you have less direct input from the adult, and you have to find more to get input in a way. And you also have less verbal space, less space to talk, less time to talk, because you're kind of competing with your siblings. And it seems that it may affect vocabulary development and maybe grammatical development to some extent. But with respect to phonological development, it doesn't seem to have that much of an effect, based on the studies conducted so far. The study, it's very difficult to so it's not clear that there is a clear association between number of siblings and articulation disorders. So to conclude, within a certain limit with person characteristic, age, gender, intelligence, etc. You don't have, well, age is important because it determines your level of development, and there are some some sex differences, but as long as you have intelligence within normal limit, and with respect to socioeconomic status and personality, these do not seem a very important factor. Okay, it's only the issue of below normal intelligence that needs to be considered very carefully, because then that it tends to be really associated with articulation disorder. The next topic has to do with family prevalence, that is, the likelihood of having an articulation disorder if somebody to whom you are blood related also has one, and this seems to be a much more important variable. Okay, so you have much higher chances of having one if there is somebody in your family that has one. And this is not surprising, given that this has been also found to happen for issues such as stuttering, as well as more recently specific language impairment, which is mostly affects grammar. Okay, so again, in these two different in this fluency disorder, stuttering, and also in language disorders, purely language disorders that involve especially grammar, you have this effect of family prevalence, okay, which indicates that there might be a genetic component to it. The next issue is tongue thrust, which is basically the inappropriate placement of the tongue in the mouth. And tongue thrust is kind of common and normal in children below 5 years of age, but then in later stages it's not typical. So there are different aspects to tongue thrust. So it's like basically the way the tongue is used during swallowing is more forward. And it's also like you see the tip of the tongue against the entire teeth when in the oral cavity. So the tongue is more forward the way it is placed. And also the tongue is more front during speech, so it's a fronting of the teeth. So it can be just a habit, or it can be caused by enlarged tonsils. So in some children, but not all, who have this, who exhibit this, it's associated with articulation disorder. So the most common is a kind of lisp, and also distortion of fricatives like the and L. And according to the American Speech and Hearing Association, it says that that services should be provided to the client who exhibit this condition if it's associated with articulation disorders. So what we've seen with respect to this literature is that there is a certain amount of normal variation, whether it's in intelligence, size of the mouse, whatever. There is some normal variations that is okay with respect to speech and articulation disorders. When there are relation between language and articulation, language and phonology, etc., there are inferences that have to be made with respect to whether you address one or the two issues. And as mentioned before, it seems that the consensus in the research is to address both of them. When you have an issue of auditory discrimination, when you have issue of sound production, so you need to assess all of those. You also need to think about whether you're going to treat them both and how. And finally, there are some methodological issues that are a challenge in terms of really identify some of these associations. Okay. That we are also going to explore a little bit when we explore the research on intervention. Okay. Thank you.